Don't you want to know what's in your arteries? Don't you want to know if you have inflammation? Don't you want to know if you've got this process where your immune system is attacking plaque? Now, I talked with a lady a couple of days ago. She was in her late 60s and she said, well, I just want to get a CIMT. She had missed the CIMT event in LA. She was close enough to have driven in, but she wanted to know when the next one was available. And I worked with her I called Heidi. I found a couple of physicians' offices, which Heidi and Todd send texts to, and maybe we can get her in there. For sure, we want to know. But it was an interesting thing. I started to have more conversation with her, and I said, well, you know, you're at an age where probably you've got like 2/3 probability of having a positive calcium score. She said, oh, well, yeah, I already had a coronary calcium test, and I do have calcium. So we knew that she had plaque. But then again, the question is, does she have soft plaque? And the other question is, very much related, does she have inflammation? And I asked her, don't you want to know if you have inflammation? Don't you want to know if you've got myeloperoxidase, high sensitivity CRP, microalbumin creatinine ratio, if your body's spilling microalbumin, whether you've got active plaque too? And she sort of paused for a minute. I said, did Clyde talk with you about the webinar series? She said, oh yeah, he talked with me about the webinar series, but we don't really need that. We've got plenty of information. We don't need to pay for more information. And I said, and I did. I said, this is our fault. We could have done it better. Instead of labeling the webinar program a lab screening program, which we should have done, we called it the webinar program. But here's the point. That's what this webinar program is about. It's getting your own labs, finding out, do you have inflammation? So the first test, let's talk for just a minute about some of the tests. The first test is microalbumin creatinine ratio. What does that mean? How does that tell you if you've got inflammation? Well, here's the thing, real quick. Each kidney is about 1 million filters, and it filters the blood. So arteries get tinier and tinier till you're about at a capillary level. There's a special type of capillary level going through one of those 1 million filters. And that filter is called a glomerulus. This is a picture of it. Here, every filter has a filter membrane. And here's the filter membrane for the glomerulus in the kidney. It's the intima. So if your kidney is spilling protein at a microscopic level, we know that you've got problems with your intima, that critical lining of the artery. We talked about this lining in multiple different places. That's what causes plaque. Again, this is the heart, the large arteries and veins. This is a clear look at a clean artery. What we're talking about is the media, which is a muscular layer which holds it together, but most importantly the intima. If the intima is damaged, it will let LDL go through and lodge in between the intima and media. It gets down to a thing called the glycocalyx. The glycocalyx is like a hairy lining of small arteries. And here's the thing. If that glycocalyx is in good shape, then LDL is not going to get through. But this is a little schematic. Here's a couple of images of glycocalyx. Here's an actual picture, but then here's an image. This is a healthy glycocalyx, and this is one that's has had injury. Smoking can cause that kind of injury to the glycocalyx. And most commonly, having a blood sugar 180 or more for hour after hour starts damaging this glycocalyx. It's like coming through and cutting grass with a lawnmower. That's what causes LDL buildup, that injured glycocalyx. That's what we want to know is going on. Now here's a couple of different views of plaque. The left side has inflammation. It's got hemorrhage in here where there's bleeding. It's got a lot of cells. This has a few cells, but this is not something that's going to break open and bleed in and leak into the artery flow, the blood flow. That's what happened here in this real picture. Prior to this crack here in the intima, this was just a brown space where you had a little bit of bleeding, a little bit of hemorrhage, a little bit of inflammation and softening. That intima lining cracked, and this is a clot. This is not soft plaque anymore. That black thing is a clot. The rest of it broke off and went to the heart and killed this patient. So yes, I would think we'd want to know, do we have this process going on? You can somewhat tell with IMT. Yes, that's very important. But why would you not want to get testing? Why would you not want to make sure? You can say, well, I got a test at the lab a while back with my doc, or you know what, I've got microalbumin, I've got test strips. These things don't work. They're looking at less than 30 milligrams per gram, and that's not what we're talking about. That's full-blown kidney disease. We're talking about microscopic levels. Here's another couple of tests. A Plaque 2 test. I won't go into detail on it, but it's monocytes. They come in, they find problems in the plaque with plaque. They start releasing Plaque 2, LPPLA2. We can actually test for that. And as you can see here, oxidized LDL actually drives Plaque 2 macrophage gene expression. You get this with myeloperoxidase as well. It's another enzyme. It's released by the cells. So if you've got this going on, microscopically, this is what it looks like. You've got immune cells, you've got monocytes, you've got what we call polymorphs. They're releasing what we call cytokines. They're releasing, the polymorphs or neutrophils are releasing MPO, and monocytes are releasing Plaque 2. And guess what? That's what we see on this blood test. Wouldn't you want to know if that's what's going on? Assuming you do, let me suggest that you consider that webinar series, in other words, the lab screening program. Thank you very much for your interest. My name is Ford Brewer. I started off my career as an ER doc, and that can be frustrating because most of the things bringing patients into the ER can and should be prevented, like heart attack and stroke. So I went to Johns Hopkins for training in prevention, did well, ended up running the program, trained dozens of docs there, and have trained hundreds and even over 1,000 doctors since then in preventing disease. What's even more important is I've helped thousands of patients prevent heart attack and stroke rather than waiting for the devastation and hoping for a cure.